morning, good afternoon, everyone. Welcome to this DCB Academy lesson on left atrial appendage occlusion, which will be presented by Dr. Marco from United States. Please, Dr. Marco.
Can you see my screen?
Yes.
Yes.
Okay. So thank you for this lesson. This is a lesson on left atrial appendage closure. I will try to do my best, and I will use some abbreviation in this lesson, such as LA for left atrium, LAA for left atrial appendage, and left atrial appendage closure as LAAC. So give me 1 second. Okay, when it all began when Michael Lish invented the first devices 20 years ago. The Plato devices is an acronym for percutaneous left atrial appendage transcatheter occlusion, and the first implanter was Horst Sievert in Germany. I'm trying to, okay. Let's start from the anatomy. What is the left atrial appendage? It's a small outpatching of the muscular wall of the left atrium and an embryonic remnant, but the structure is highly variable. In general, as a gross anatomy, we can distinguish 3 parts. We can distinguish an ostium. This is the most important part for an interventional cardiologist because it's the part that we want to occlude in order to prevent thromboembolic events. The neck, as you can see in red, and the lobar part, that is the most variable part. Let me know if you are able to hear me. And after that, we can understand why. What is the rationale for left atrial appendage occlusion? The rationale comes from 2 studies, one from Blackshear and another from Hagen, that understood that studying from autopsy or transesophageal echocardiography that in patients with atrial fibrillation, more than 19% of the thrombi were located in the left atrial appendage. So for this reason, there are 3 elements that can justify this type of procedure. The first element is that atrial fibrillation causes strokes. The second element is that the strokes are associated with thrombus formation in the LAA. The third element is that thrombi causes strokes by embolization to the cerebral circulation. In general, are described 4 types of anatomic shapes for left atrial appendage occlusion, or chicken wing, cactus, wine sock, and cauliflower. In general, the cauliflower is most frequently associated with cardioembolic events because it's rich in terms of pectinate muscle, so there is most probability that the blood forms clots. In this case, you can see here the morphology from the transesophageal echocardiography, but you can see the same morphology in the TEE, in the angio, and in the CT scan. Apart from this, I don't think this is a very important topic because in general, we can ask to us different anatomies, different approach. I don't think so, because in general, we can use a sort of metaphor. If there are different types of bottles, and we want to drink some water, we don't care about the shape of the bottle. We care only about the cup because we want to drink. So it's the similar concept. We want to work in the first 3-4 centimeters of our structure, that in this case is the left atrial appendage. We have 2 types of approach, a transcatheter closure or a surgical occlusion, but we will focus today on the transcatheter approach. But what is the indication? What are the indications for left atrial appendage occlusion? This is a consensus statement from the EAPCI, the Munich consensus document, that established that in general we have to focus on 2 different types of population: the high bleeding risk population, with population with history of major or minor bleeding, with or without oral anticoagulant therapy, that can be at increased risk for bleeding due to physical condition and comorbidities. So patients that had a bleeding event or are at decreased risk for bleeding events, as we can see, there are lots of type of disease and bleeding that can occur in this case. Or there is a second type of population, inability to take the oral anticoagulant therapy for different reasons: intolerance, pure adherence, variability in the INR or warfarin, and there is a new indication. This is the patient choice. This is an example of a patient, a very active lifestyle, 70 years old, that, for example, doesn't want to take the anticoagulant therapy for the risk, for example, of intracranial hemorrhage if he makes, for example, some types of sport or work activity. Another population, as we can see as a B ladder, is the thromboembolic. In this case, is completely different because we are not talking about reducing the bleeding risk. We are talking about reducing the thromboembolic risk. So as left atrial appendage closure in this case is an addition to the anticoagulant therapy. And this is the case of patient that had a stroke during anticoagulant therapy. So how can we divide our patients? What is the best patient for these procedures? We can indicate some 5 types, different types. The black one patient is the contraindicated. He's not able to take oral anticoagulant therapy. The bleeder is the patient that experiment bleeding, previous bleeding on OAC. The future bleeder, so patient that didn't have bleeding events, but they are at high risk, such as patient that has Parkinson's disease or very high risk for falling. Non-compliant patients, the GRI patients, tolerant but not taking the oral anticoagulant therapy, they are non-compliant, and patients with active lifestyle. This is the practical algorithm that we can use, for example, to decide when to candidate a patient to left atrial appendage closure. And as we can see, it's quite clear because if the patient can take the oral anticoagulant therapy starting from the left of your screen, the patient has to take the oral anticoagulant therapy. Now, obviously, we can prefer the new anticoagulant drugs. If the patient is at elevated bleeding risk, if the patient, or the patient as an individual specific risk of constellation for stroke, for example, in this case, we have to evaluate an individual risk-benefit analysis and decided for new anticoagulant therapy of VKA or left atrial appendage occlusion. In general, we can apply this type of algorithm for patients that are unwilling or unable to take oral anticoagulant therapy. And let's try to advise the anticoagulant therapy. And if the patient decides to refuse this type of approach, we can candidate him for left atrial appendage occlusion. At the end, there is a population with absolute contraindication to oral anticoagulation, and this is the typical patient who we perform this type of procedure. There are different types of devices, different type actually available, but in general, there are 2 big families: the plug families, the pacifier families. The plug families are endocardial devices which occlude the neck of the LAA. And the most important device in this family is the Watchman device. As you can see, the device is applied to the neck of the LAA and occlude the entrance of the blood inside the left atrial appendage. Or we have the pacifier. The most important device is the amulet. You can see the circle, and the approach is quite different because we have 2 parts in these devices. A plug part as the Watchman device, but we have a disc. So we have the plug in the neck and the disc that permits the completely occlusion of the ostium. There is a third family that had no luck in the commerce, that is the LAA body ligation. It can be performed with an epicardial or endocardial approach. This is the lariat, but we cannot stay here to talk about this because it's not so diffused. This is the typical patient. Before to talk about studies on left atrial appendage occlusion, I want to show you a typical case to give you an example of how to perform these procedures. This is a typical patient, a patient with contraindication for oral anticoagulant therapy, and he is a bleeder because he is a patient with myelodysplasia, anemia due to gastrointestinal bleeding, low hemoglobin, required hemotransfusion, obviously with atrial fibrillation, so a very high risk bleeding, as bled 5. Remember that an ASBLED score more than 3, the patient is an high bleeding risk. So it's a perfect patient for left atrial appendage closure. The procedures, in the procedure, there are different parts. I decided to show you a procedure because we can say a different audience, no? So we can understand everybody what we are talking about for a technical point of view, not only from a theoretical point of view. We can use a transesophageal or a nice intracardiac guidance. The most important thing is to exclude the presence of the thrombus in the LAA, because to perform a procedure with a LAA thrombus is a very high risk for embolization. The vascular access is a femoral vein, generally the right. Then we arrive to the right atrium. On the right atrium, we perform a transeptal puncture and go to the left atrium. At this point, we evaluate the anatomy of the left atrial appendage, the ostium, the depth, the presence of multiple lobes. We decide for devices, we position the device, release the device, and then we evaluate our, we perform a post-release assessment. We can use the TEE and the ICE, we said. So transesophageal echocardiography or intracardiac echocardiography. What are the differences? Two main differences. With the TEE, we are able to have a more spatial resolution. So it's a quite safe procedure, we can say, mainly for the first operator or of an experienced operator. With the ICE, where is the advantage? The patient, we don't need to sedate the patient. So the patient is completely awake. So it can be discharged, for example, in the same day. There is a new approach that is quite new, just published on JACC Intervention, where a group from Italy used the intracardiac echo, but for throughout a transesophageal via. This is a new approach, but an hybrid solution, we can say. As we can see, I show you the images from two different approaches. Here you can see a transesophageal echocardiography and the measurement of the LAA, and you can see below the ICE images. And as we said before, two different approach, the pros and cons for both approach. In general, in the world, the TE is the most diffused. Only to give some data, in the United States, only 12% of the centers use the ICE, the intracardiac echocardiography, to perform the left atrial appendage equation. At this point, we assess the LAA, we rule out the presence of thrombus. If there is a thrombus, we cannot perform the procedures in general. We prescribe our anticoagulant therapy for 4 or 8 weeks, and then we will repeat again an imaging procedure such as the TEE to evaluate the presence or not the thrombus. But we do the procedure in this case. We take a femoral vein. We arrive in the right atrium, as you can see from the images from the TEE and angio. We perform a transeptal puncture, and because we want to go to the right, to the left atrium. 90% of the cases, we perform a posterior inferior transeptal puncture in the fossa ovalis. You can see from the images what is the reason. This is the fossa ovalis, and the blue part. And if you perform a superior puncture, such as for the mitral transcatheter to edge repair, the risk is that we are not able to arrive to be coaxial with the ostium of the LAA. So in general, we want to do always an inferior puncture. In general, when we perform a transeptal puncture, we want to stay always posterior, because if we stay too anterior, the risk is to puncture the aorta. We do an evaluation. We measure the ostium and the depth after that we cross into the left atrium, and we want to evaluate the presence of multiple lobes of the LA or accessory lobes. And this is very important because there is the risk of a per-device leak. And we chose our device. How do we choose our devices? We chose our device based on the measurement of the ostia in different projection, and we use always the biggest measurement. I want to show you a table where you can understand now there are different sizes for the device, but every device is chosen based on a range of the ostium, because our device, our goal is to have a very well compressed device, because you want to avoid an embolization. Yes, we want to close the LAA, but you want to avoid the embolization in general. There is an oversizing of the devices compared to our measurement of the ostium. In general, we use a 20% oversizing. So if we have a 50 millimeters ostium, we choose a 20 millimeters device. We position our device on the left, and then we deploy our device, and we check with the contrast if there is if this is a good position. After that case, we perform a good tag test. Tag test means that we push the device if it is stable to avoid future embolization. You can see the same things performed as animation, as angio, and as a TEE at 45 degrees. And at the end, after that, we have satisfied all the release criteria, the location, the stability, the sizing, and the sealing. Sizing means very good compression, as we said before, because we are able to measure the device compressed after deployment. The sealing, there are no leaks, because if there are leaks, we did not reach our goal, just to completely seal the LAA, and we release the device. After releasing, it's important to reevaluate everything, mainly in terms of safety. If this is an endocardial procedure, so there is always an intrinsic risk of complications, such as pericardial effusion. In this type of procedures, is essential an evaluation, a follow-up. 1 4-month assessment in general is advised with a TEE or CT scan. Why do we do a follow-up? Because you want to check for 3 important things. If there is the device, if the device is not embolized. Second thing is to exclude the presence of thrombus attached to the device, so the device-related thrombosis, and a residual leak. In general, we talk about an unsuccessful procedure when we have a peri-device leak more than 5 millimeters, but this is a number that is quite discussed in the literature. So what are the scientific evidence about this procedure? Everything started with the PROTECT-AF trial. The PROTECT-AF trial randomized 707 patients with non-valvular atrial fibrillation, at least one risk factor, to device Watchman or warfarin. Randomization 2:1 and a follow-up of 3.8 years. This is a non-inferiority trial, and as we can see for the primary efficacy endpoint, generally this type of trial on left atrial appendage closure is frequently a composite of stroke, systemic embolism, cardiovascular mortality, and major bleeding. The devices met the non-inferiority. The big problem for this trial regarded the safety endpoint, because there was a very high percentage and rates of procedural complication, mainly regarding pericardial effusion and pericardial component. In this case, the antithrombotic regimen chosen by the author was aspirin plus VKA for 45 days, followed by a ZAPT for 6 months, only if after 45 days a TE or a CT scan showed the absence of thrombi and peri-device leak. After 6 months of the APT, the patient continued with the aspirin lifelong. So, in consideration of all these complications, Boston Scientific decided to do another trial. The same trial is the PREVAIL trial, only to show the safety of this device. It was designed in the same way, as you can see. The only thing that it changed is the follow-up to 18 months. And as you can see from the results, comparing the PROTECT-AF, the PREVAIL, and the CAP, that is a big registry, multi-center registry, post-marketing registry, sorry, the number of complications, 7-day procedural complication, reduced dramatically from 9% to 4.5 in the PREVAIL, from PROTECT to PREVAIL. And this is very important because it showed as probably the mainly issues about the procedure was the operator experience. As you can see, during the years, we started from PROTECT-AF, which 10% of procedural complication, and we arrived now with the evolution registry that the number of complications is 2.8% nowadays. So as safety procedures. The procedural success increased during the years. As we can see, we started from a 91% from the PA, from the PROTECT-AF to the PREVAIL, 95%. Now, post-approval, we are at more than 95%, but we will see the data from the last trial that increased more and more. This is a meta-analysis from the prevalent and PROTECT-AF, the two trials that we have seen, that show that left atrial appendage occlusion determined a reduction in 27% of all-cause mortality, 52% measured bleeding, 55% in disabling stroke. The trial we have seen, the prevalent and the PROTECT, are focused mainly on VKA. There is a trial, the Prague 17 trial, that focused mainly on new oral anticoagulant therapy or direct oral anticoagulant. This is a trial that enrolled 400 patients, high bleeding risk, high thromboembolic risk, median follow-up of 3.5 years. And as we can see, this is a non-inferiority trial to the most used anticoagulant drug was the apixaban. As we can see, for the primary endpoint, always a composite of thromboembolic endpoints, measure bleeding, and the complication, that the device met a non-inferiority with the anticoagulant, the anticoagulant drug. Same things for the stroke or TIA, and the device was able to reduce in a statistical significant way the non-procedural clinical relevant bleeding. In this case, as you can notice on the right, the antithrombotic therapy post-implantation was different because the author used aspirin plus clopidogrel for 3 months, and then aspirin long life. The procedural related complication was 4%. And this is the meta-analysis which comprised the Prague 17-2. The results are quite similar compared to the previous meta-analysis with the 3 trial, and there is a risk of 78% for hemorrhagic stroke, 47% for major bleeding, and 37% for all-cause mortality. This is the last trial that was performed regarding the left atrial appendage closure. This is the AMULET ID trial. This is an important trial because AMULET had to show the non-inferiority compared to Watchman to be approved in the United States, so for the FDA approval. First things, there is non-inferiority. This was quite expected because AMULET is safe devices. Another important thing about this trial is not about a non-inferiority because it was expected, but what is the difference between these devices? And this trial showed 2 important things. The AMULET devices gives us more pericardial effusion. And this could be expected because it is a 2-component device, so the disc increases the risk for pericardial effusion. Second things, the AMULET has less residual leaks, as we can see on the bottom and on the right. The residual jet at 45 days does not depend on the sizing of the leak, 0 millimeter, 0 to 3 to 5, or more than 5 millimeters. The AMULET performs always well than the Watchman. And in this trial, the procedural success was very high, 99% for AMULET, 97% for the Watchman. What are the ongoing trial? I think the most important trial in this moment is the Champion AF, because it can be a really game changer trial. It's the first trial that want to show if the left atrial appendage closure first-line therapy for thromboembolic risk reduction is comparable and non-inferior to anticoagulant therapy. So this can be a really game changer because it will randomize every patient with atrial fibrillation with low bleeding and thromboembolic risk. There is an important trial, the option trial, which compares Watchman Flex with oral anticoagulant therapy for post-atrial fibrillation ablation therapy. And I want to show you the actual indication after the implantation of a left atrial appendage closure devices. This is at the 2025 European Society of Cardiology guidelines for the management of the AF. As we can see, during the years, the things are changed because now we are able to prescribe a low dose of aspirin and clopidogrel for a short period of time, between 1 and 6 months, and then we can give these patients aspirin long life. In low bleeding patients, we can decide to give in the first phase for 45 days an oral anticoagulant therapy what is the reason? Because there are this type of indication we arrived only after all these years to avoid.
Hey, Marco,
yeah.
Excuse me to interrupt. Yeah, just jumped in, and thank you for your presentation. This is a very interesting phase of the presentation. My question is, recently for stents, there is a sort of change in the scenario for antiplatelets with more and more patients that get treated with a clopidogrel instead of, and you drop the aspirin instead of clopidogrel. So what about Watchman and Amulet? What about LAO? Is there any study showing that you can, because these are high bleeding risk patients mostly, okay? So these are patients that may bleed from the stomach, so they may have a gastrointestinal bleeding. So here the aspirin is not doing a good job. So is there any data that is showing that you should use a dual antiplatelet therapy, then you drop aspirin, you go on with the clopidogrel?
There are some studies, but are not focused on retire the aspirin and give only the clopidogrel. Mainly, there are some studies, sub-analysis of the evolution registry, where they tried to give only one antithrombotic, such as an SAPT, only clopidogrel for patients with high bleeding risk.
We did a study with the Fondazione a few years ago of a very small, limited number of, it was less than 50 LAO, but we did in many cases single antiplatelet from the very beginning, and they went well. We have a 6-month echocardiography surveillance which showed just only one single case of prostasis thrombosis that we managed with anticoagulation, short-term anticoagulation. Yeah, for a month, I think 1 or 2 months, and then we did another echo with the resolution of the thrombosis. So I think it's safe to go in selected patients with single.
Yes, in my opinion, is a safe approach. There are, as I was saying, there is a sub-analysis of the evolution registry and a sub-analysis of the NDCR registry from the United States. Obviously, you have a little bit more cases of the vascular thrombus compared to the double antiplatelet therapy, but in patients with a high bleeding risk, there are no other solutions. Sometimes in the clinical practice, and this is true, some patients are discharged without antithrombotic therapy if they are at very high bleeding risk.
But Marco, Prof, good evening. Can I just say a thing?
Yes.
Has been just recently published randomized clinical trial that unfortunately from my center here in Spain, that is the Atrial trial, and what has emerged is that even if with many limitations, it enrolled just 90 patients, and they decide to randomize the patient to DAPT or small low dose the DOAC, so 2.5 DOAC, and what emerged is that and apixaban 2.5 milligrams every 12 hours, and what emerged is that a low dose of apixaban performed better than the DAPT, and is what they are trying to test in the bigger Andes trial.
Yes,
that is currently ongoing.
Thank you.
So
it performed better in terms of what? Which endpoint?
In terms of reduction of bleeding, the primary endpoint was in the Adala trial was a composite of safety, was measure bleeding and efficacy. So was thromboembolic events and the device-related thrombosis at the 3 months. So they had many problems with the COVID, so they had to reduce to interrupt the inclusion. So it was a trial, randomized clinical trial, published in JAMA as a correspondence. But I think that there is also a nice meta-analysis conducted on, has been published like 1 year ago on JACC. There is, unfortunately, based only on registries and small observational trials, that seems to support the evidence that low dose DOAC performs better than any antiplatelet therapy.
Yes, Giovanni, thank you for your comment. The problem is that in this case of approach, this is my opinion. I think this can be probably the better approach, low dose of anticoagulant, because the first work was done from the group of Andrea Natale in Houston, where they gave a small dose of rivaroxaban for this patient. This performed well. Same things for this article published on JAMA. Probably that is necessary is a big trials to show this difference of these things with this type of approach, because probably in this type of thrombus on the devices, the anticoagulant approach is better than antiplatelet approach. This is my opinion in general, what we have seen about the other anticoagulant therapy.
Grazie. Thank you, Marco.
My pleasure. So what I want to show you is that it's very important to understand that the device-related thrombosis during the years did not reduce. In general, it's always a value from 3-4% of all the patients. And it was not so dependent about the type of devices and the antiplatelet regimen. So this is one of these aspects of this procedure on which we have to work to improve. Why is important device-related thrombosis? Because the device-related thrombosis increases the risk 2 to 4 times the risk of thromboembolism, as we can see, to 2 to 4% of the patient within 1 year after LAO. And there are some independent predictors such as the age, the female sex, the permanent atrial fibrillation, left ventricular dysfunction, high CHA2-VASc, and coagulopathy, renal disease. How to manage with DRT? Now, what we can do is to prescribe long-term anticoagulation, probably the new anticoagulant therapy, the anticoagulant drugs, and the frequent surveillance. Another big problem, as we said before, about the left atrial appendage occlusion is the peri-device leak. The peri-device leak that can be on different sizing and different shape. From different studies, from the AMULET, from the NCDR registry, from the Watchman trials, show that more leak means more events. The big problem about the peri-device leak is that in literature the authors are not able to convey what is the best sizing to describe a dangerous leak. In general, we describe as more than 5 millimeters, but now there is the idea to consider a dangerous peri-device leak with more than 3 millimeters. How to deal with the peri-device leak? In general, the dangerous peri-device leaks
mostly important is how to understand it. So, which is the best way to do a diagnosis and also to measure it?
Now
it's a CT scan or echo surveillance.
We are sure that now the CT scan is better. Is for sure there is more sensibility for the CT scan to measure the leak. This is sure. And because not only in terms of measurement of the leak, but to understand what is the reason why. The type of leak, if it is a subfibril leak, if it is a leak of a partial lobe opening, so the CT scan is more sensible. The problem is that the universal approach from this point of view, because more than 90% of the center uses the TE to detect a leak.
Okay, thanks.
And we were saying that what is a very dangerous leak in general? If we have a visible communication between the left atrium and the left atrial appendage, the diagnosis of peri-device leak is important for the PDL diameter, PDL mechanism, as we said before. And in general, when we consider a therapy, as we can see from this flow chart from Mohamed Al-Khoury group from my own clinic, clinical significant leak is a large leak, more than 3-5 millimeters with uncovered lobes. We are sure that this type of leaks are related with in an increasing in thromboembolic events. So in this case, we have to consider a therapy. What type of therapy? In this case, we want to think about a closure, this type of leak. We have four different type techniques, we can say, difficult procedures for experted operators with expertise. And we can use a second device, as we can see, deliver embolic coils, plug and occlude a radiofrequency ablation. For the other type of leaks, such as clinical uncertain leaks, small than 3 millimeters, small proximal LAA leaks, or subfabric leaks, we can say the approach can be the observation, because we are not sure that they increase the thromboembolic events. When we say a fabric leak, we are talking about a leak that is related to a flow inside the device, but we cannot see a clear leak at the side of the device. Oh, this is my final provocation. This is the last 3 trials. This is the trial on cardiac surgery patients. That this type of trial is very important because changed the guidelines, and 4,800 patients were randomized to left atrial appendage closure or no left atrial appendage closure. This type of patient undergoing cardiac surgery for other reasons, and obviously all patients with atrial fibrillation, and the cardiac surgeon decided to close or not the left atrial appendage closure. All these patients, this is important, continued the oral anticoagulant therapy, 80%, with a mean follow-up of 4 years. Why this trial is important? Because the goal of this trial was to understand the potential role of left atrial appendage closure to reduce the thromboembolic events, so as an additive effect with the oral anticoagulant therapy. As we can see for the primary outcome.
Marco, sorry to interrupt. I still have the doubt that, at least in my case history, the vast majority of these patients are really at high bleeding risk. So it's not the typical US patient where he can decide or she can decide to drop the anticoagulant and have the LA occluded. In Europe, at least, the vast majority of the patients have really high bleeding risk. So it's almost impossible to think to go on with a prolonged anticoagulation after LAO in a real practice, I mean.
No, I know. I'm talking about at least 5-7% of the patients that are not at very high bleeding risk, but they experience a stroke during the anticoagulation. In this case, we can try to use this type of therapy. Okay. The result of this trial have been astonishing, because there was a reduction of 33% at 4 years in terms of ischemic and stroke, ischemic stroke or systemic embolism, systemic embolism events, 4.8% in the LAO group compared to 7% in no LAO group. This is the reason why they decided to design a trial with a transcatheter, in this case left atrial appendage occlusion, 750 patients with atrial fibrillation with ischemic stroke or transient ischemic attack within the 6-month period of enrollment with an adequate regimen of oral anticoagulant therapy, and be randomized to continue the DOAC or perform left atrial appendage occlusion without interrupting the anticoagulant regimen. Follow-up of 3 years until 10. So what are the future directions of these procedures? In my opinion, for my conclusion, evaluate the role of the left atrial appendage occlusion in reducing the residual ischemic risk, investigating new antithrombotic regimen to reduce the rate of DRT, and understand this impact on stroke rates, because this is another cloudy field. In these procedures, new devices which do not require DAPT post-LAO. There are some studies, some new devices such as the class devices that are foam-based devices, which ideally should not require post-DAPT. The clinical impact of peri-device leak and establish a real cutoff and an high-risk type of peri-device leak. At the end, a follow-up, a standardization criteria for post-implantation surveillance for CT scan or TE. Thank you for your patience.
Congratulations, Marco.
Very nice presentation. I really loved it. It wasn't hard for me to understand the concept. I think that it was very medical student friendly.
Thank you.
Yes,
I tried
very
to
nice.
be.
Great job, Marco. Guys, do you have questions for Marco? Specific question or according to your expertise or non-expertise in this topic.
So I
Yes,
just
may I? Oh, go
sorry,
ahead.
sorry, no,
Yes.
Sada, go ahead, please.
Oh, thank you very much. Yes, Dr. Marco, first of all, thank you for this very comprehensive and nice presentation. I have a kind of curiosity. So you mentioned that this there is a device-related thrombosis risk for which you gave anticoagulant therapy, but these are mostly high bleeding risk patients. And you aim to like perform this procedure to prevent giving anticoagulant therapies to these kind of patients. So
This is a good
based on
question.
based on your experience, how would you like manage this kind of situation? What is your like suggestion based on your experience?
What you can do is try, because there are no randomized trial that give us a guide from this point of view. So if you have a patient, you give your double antiplatelet therapy after the procedure, and 2 months later you do a TEE and you have a device-related thrombus, what you can do is suspend the double antiplatelet therapy and start with a new oral anticoagulant drugs, and cross fingers that the patient has not a bleeding events. In case the patient has a bleeding events, you can try to reduce the dose of anticoagulant drugs, and let's see if the patient is able to tolerate it. It's quite difficult to manage this type of situation. If the patient is a very high bleeding risk, you have to follow the patient.
Yeah, the alternative could be to go without any antiplatelet or anticoagulant until the bleeding risk is reduced. I mean, if the patient has an active bleeding that can be somehow fixed or passivated, or an alternative could be to go with just one single antiplatelet, as you were saying, or the last chance is to go on with, it's very nasty to say, with a transfusion. Also I had a couple of patients that had to go with a sort of weekly transfusion for the first months. Then we could drop any anticoagulant and any antiplatelet.
Yeah. Another important thing is that the type of DRT, so the type of device-related thrombus. Because if you have a very big thrombus that gives a communication with the left atrium, you have to treat it because the risk of embolization is very high. If you have an embolization a thrombus only in the screw of the device, or only a small formation, there is probably less probability of cerebral embolization. So you have to evaluate every patient in this case, but if possible, the patient should take an anticoagulant drug.
Okay, thank you very much.
Thank you, sir, for your question.
Dr. Marco?
Yes, Cecile.
So I have a question. It's kind of inspired by Tavi because because of the lesson last time. So do you do any CT imaging prior to the closure of the left atrial appendage to make sure that there's no mismatch of the device and the where you're gonna install it?
So if you have to perform a nice procedure, so a procedure with intracardiac guidance, it's better that you perform a CT scan compared to a TEE, because the CT scan gives you a lot of information compared to the TEE. But in general, if you perform a CT scan or a TEE, regarding your question, you have these type of devices are very conformable with the ostium. So you always calculate before the percentage of compression compared to the ostium measurement. So if you have a 20 millimeter ostium, you want a 20% of compression, you choose a 24 devices. Such as this is the practical approach, because you want a compression between the 15 and 25%. So a very compressed devices, but no so compressed, but device has to seal the LAA and reduce the possibility of embolization in general. You can do it with a CT scan or with a TE. It's the same, we can say. But the CT scan in general gives you a lot of more information, not only in terms of device sizing.
Yeah, okay. Thank you. One more question. Did you ever encounter after such intervention a pericardial effusion?
Yes, in general, the pericardial effusion is most frequent, and different studies showed it. The pericardial effusion is more frequent with the ICE approach because you have a less spatial resolution compared to the transesophageal echocardiography, and sometimes happens 2-3 times more. And is an endocardial procedure, and every endocardial procedure has their intrinsic risk of perforation of pericardial effusion. So yes.
Okay. Thank you very much.
Thank you, Nathan, for your question.
Marco.
Okay, nice.
Marco.
Giovanni, you have another question?
I have a question. You showed a nice slide that was indicating like the predictors of the DRT device related thrombosis. But do you really think based on your experience that there are some procedural issues that really can determine and make the risk of DRT higher? Because it is is a quite new procedure that we perform, and there is no real standardized approach. Someone looks at the close like circumflex lobe and LCP and stuff like that. But do you think that a procedural issue can have an impact on DRT? And the second one, if you should decide on the best, do you have a best the best device for you in terms of rate of pericardial effusion and stuff like that? If you should conduct a randomized clinical trial, which would be your favorite device and why?
Thank you, Giovanni, for your question. Very interesting. This is my opinion. So let's start from the first question. What I think about DRT and procedural characteristics, the most important things, in my opinion, is that the device is placed in the right place. So if you have a very deep devices in the LAA, probably you have an high rate of device-related thrombus because there is more space in the last part of the left atrial appendage that is open, we can say. So if you put a very deeper device in the LAA, you have a major risk of device-related thrombus. There are some observational studies that say this, but in the clinical practice, you can notice it. And this is the first one. For the procedural characteristic, mainly this is the things. Some authors says that if you have a loss of shoulder of the device that is present in the left atrium, this can be a big problem regarding the DRT, but we can say robust data about this. Regarding the device on the pericardial effusion, it's clear that for the pericardial effusion, the plug and disc devices gives more pericardial effusion because the disc is biggest compared to the plug, and the data shows that an amulet gives more pericardial effusion compared to the Watchman flex. For the other ends, you have less leak with the amulet, so it's a balance, we can say. If I should do a trial based on pericardial effusion, for sure I would choose a Watchman devices, a plug devices in general.
Amazing, thank you.
Thank you, Giovanni.
Thank you, Marco, for the great presentation. I have a question. Do you have any experience with 3D printing for as a pre-op planning? There are some studies. I'm not aware of any RCT. There are some observational studies that show that 3D printing can reduce the para device leak and improve.
Sorry, you say 3D simulation before?
3D printing, yeah, 3D simulation
3D
printing.
Okay. No, I have no experience about this, about 3D printing before. I have to say the truth. I work in 2 different centers with 2 different approach, one on TEE and now in the United States they work with CT scan before and eyes, intraprocedural eyes, but I don't have experience about 3D printing from this point of view.
Thank you very much.
Thank you, Jesse. There are any other questions?
So thanks a lot. Thanks a lot, Marco, for this comprehensive. It is the second part presentation. I will ask you, please, to send me also the first one. No, it's a pleasure, really. You have done a very good job in rendering, like Justin was saying, something which could be complex, easy to all of the different level of expertise and knowledge at the DCB Academy. This is not common. This is not common. So I appreciate.
Thank you.
Okay,
Thank you,
so
really.
I don't think we have specific information. We have a deadline which is quite close, which is the proposal for abstracts and late-breaking trial and cases to be sent to CRT under the label of DCB Academy. So I don't remember how many days. Sarah, do you remember how many days do we have for the proposals?
So the deadline is 10th of November.
Okay, so today is the 8th, so it's the weekend. In the weekend, again, if you have a good idea on something that we are going to publish, is under review, or something that we can do fast, we would like to send some proposals to CRT in March, Washington, March, where actually there will be, there will be a symposium organized by my institution, well, by DCB Academy, and also with the label of my institution. So it's a great opportunity, I think, for all of us.
Yes, thank you very much, Paul.
Thank you very much.
Okay, that's it. So
that's it.
Have a nice weekend.
Thank you, guys. Have a nice weekend.
Thank you.
Thank you.
Bye-bye.
Thank you.
Thank you all. Bye-bye.
Bye.
Thank you.